So genuine empty follicle syndrome is rare. This is when we fail to retrieve oocytes from mature follicles with optimum HCG levels on the day of oocyte retrieval or optimal LH levels 12 hours post agonist trigger. So how do we do this? Do any of you check the LH levels after giving your trigger? Any doctors, like if you're doing IVF stimulations, do you check LH levels post trigger?
No, ma'am. I do IUI, but never check LH level after giving trigger.
For IVF, I'm asking.
No. Sorry, ma'am. I don't do IVF.
Okay. So usually what we do is when we give a agonist trigger, like say if I've given at 10 p.m., then around 9 a.m. in the morning next day, we would have tested for the serum LH levels. And based on that, we are able to get a relatively fair idea about whether the trigger has acted well or not, and whether we are staring at some condition like this. So most often we do, almost for all patients whom we give agonist trigger, we do this 12-hour post-trigger LH. And here what happens in genuine empty follicle syndrome is even if you give a repeat trigger, you will not be able to rescue the cycle because it is a genuine case. There is some problem and it is not related to the trigger alone. Whereas false empty follicle syndrome is the one which is most common. Here we'll be able not to receive the, we'll fail to retrieve the oocytes with low HCG levels less than 40 international unit per deciliter due to error in administration or because of decreased bioavailability of HCG. Or it may be that the agonist trigger was not given properly. Here we can rescue it with a repeat trigger. So that's why we do the repeat this lupride. When we give agonist, as I was saying, say if I've given at 10 o'clock in the night, I will do a serum LH level. And if the value is low, like if it is less than 15, then we repeat with one more trigger. Same injection we give when a double dose, and then we plan the OPO around the same time. So there at least one of these trigger will act, and then we'll be able to rescue the cycle.
Would you please repeat the level of LH?
I'll tell you in detail. Usually we take it as 15. Most of the studies have shown that if your level is above 15, then you will be able to retrieve the follicles. You will not encounter EFS. Then there are the borderline forms of empty follicular syndrome, which is where we get very few mature or immature oocytes are recovered from several mature follicles. And this may be explained by a defect in process that results in oocyte maturation and cumulus cell expansion. So there is some problem happening here with receptors, and because of which that proper cytoplasmic nuclear maturation is not happening in some of the oocytes. We will be able to maybe retrieve less than the expected number of oocytes. Then Stevenson et al. In 2008 described the incidence. He said the incidence of genuine empty follicle syndrome was 33% and false was almost 67%. And he had given the cutoff to differentiate each one of them. So whether it is genuine or whether it is false empty follicle syndrome. Sorry. So if you have given HCG trigger and the value is 5 to 160 after 36 hours from the exogenous trigger, that is the cutoff. And this was another Duke et al. In 1996. He had given the cutoff as 10 milli international unit per liter with 100% sensitivity and specificity for predicting empty follicle syndrome. So he said if it is less than 10, that means the trigger was not given correctly. And here they had given the, as you were asking, the serum LH cutoff was 15 international unit per liter, and this is what we also follow. And what do we do normally? Like, how can we assess, see, like you would not have anticipated definitely, like you have started the OPO and then you realize you've completed one side and the embryologist says that there are no sites retrieved. So what do you do?
Ma'am, repeat trigger can be done. Another ovary we should not
No,
touch.
but how do we know whether it is real, genuine or false?
Oh,
Empty follicle. See, if it is genuine, even if you give trigger again and do, you will not be able to rescue the cycle. No? So first you need to know whether it is genuine or whether it was some error in giving the trigger, isn't it?
yes, ma'am.
So like immediately what can you do? Obviously, if you send, see, they're giving this like level cutoff as 5 to 160. So where, what do we do normally if you have to send beta HCG? When will you get the report? At least 1 or 2 hours you will take, no, to get the report. Can we do something else on table?
PT.
Yeah, on what? Patient is under anesthesia, bladder is empty. How to do UPT? So what are we testing? UPT may we are testing HCG levels, right?
HCG
Hello.
level. Yes, ma'am.
So to come positive, UPT to come positive, that means the beta, like your HCG levels are good enough. And when will it be good? When you've given the trigger correctly. But how do we get the urine there? So what we do is we take the follicular fluid and then do a card test with that.
Okay,
Can you
ma'am.
hear me?
Yes, ma'am. Yes.
Okay, so what we'll take the follicular fluid, get a card, pregnancy card test, and check UPT with that. So if it comes positive, that means the trigger was given correctly, and we are dealing with a genuine empty follicle syndrome.
Okay, ma'am.
Okay, and also to cross check, you can send the beta HCG in blood. So that value obviously you will get 2-3 hours later, but at least you will get some idea and you will be able to counsel the patient. Okay, so how will it impact you in, obviously it will result in cancellation of the cycle and a lot of anxiety. And I've seen situations, I mean, we really get very stressed out and it is more sporadic even rather than a syndrome, and lack of HCG threshold levels, and we don't have the actual HCG levels which will really differentiate. As I showed in the previous slide, the range was very wide, from 5 to 160, anything it can be there. And still we don't know whether it was genuinely empty follicle or whether it is false. So we don't have a correct threshold to help us differentiate between these levels. And the choice of patient population, so ovarian stimulation cycles with good ovarian response underestimates the incidence of around 30% of IVF population who are poor or suboptimal responders. So it depends upon the choice of the patient population also. And this was a study published by Kim and G et al. In 2012, and they had studied 705 IVF cycles where they excluded the poor responders. And in GnRH agonist and antagonist protocols, they found that the prevalence was 2.4%. So it was comparable in both types of protocols. And in 2015, Madini and Jahangiri, they had done a study on 3,000 odd IVF cycles, and they found the prevalence to be 1.7% in mini flare GnRH protocol, which was done for low ovarian reserve women and especially older women. And one more study by Franco et al. And he found that the empty follicle syndrome was associated with ovarian aging. Then one more study by Castillo et al. And 2034 egg donor cycles they studied who were given GnRH trigger versus 1433 cycles with self eggs, and it included poor responders of any age with HCG trigger, and they found whether it is donor or self cycle with whatever trigger you give, the prevalence of empty follicle syndrome was same. So it is not related to what type of stimulation you are giving, what type of trigger you are giving. It can generally vary between 1.5 to 2.5%, roughly, you can remember. So it is as such not very common, it is very uncommon. So if we say 1.5 to 2%, so almost like if you have seen 100 cycles, you may have come across one or two cases of empty follicle syndrome. So it can vary from 0.05% to 7% of patients who are going ovarian stimulation. And obviously the inclusion criteria will be different. In some studies, patients with poor ovarian response or premature ovulation were also included, while in others they were not. And there were no specific stimulation or triggering protocol which is related to the occurrence of empty follicle syndrome, which we had seen in the previous slides also. When we talk about genuine empty follicle syndrome, it is not very common. It is like almost up to 1% only. However, if it is really genuinely empty follicle syndrome, then the recurrence rate is very high, and counseling is of profound importance, especially in advanced age group. And Velasco et al. Had, in one of the studies, he said that if one cycle you get with empty follicle syndrome, there is 20% chance of getting the same thing in subsequent cycles. So we have to counsel the patients accordingly. So when you do the beta HCG levels and you have the values, you know that, and you have checked everything that the stimulation or this trigger was given correctly, correct, the drug was correctly maintained, then you can counsel them about the recurrence. Then about the false empty follicle syndrome. So what happens here is, as we were discussing, it may be related to HCG related falls, which is the main mechanism. So they might have given HCG injection later than the schedule. So maybe 11 hours before retrieval. So sometimes the nursing staff would have done that. They would have given the injection late, or the patient would have forgotten to take it on time if you are giving it outside. So that's why we prefer to give all our triggers in our center and by our staff only, because we don't know who is giving, how they are giving, at what time they are giving. They might manipulate the timings also, or the patient may herself forget. So when you do it in your own center, we usually send them reminders half an hour before. Make sure they reach us 15-20 minutes before. So those things you have to keep in mind so that you don't come across this scenario. There may be even a failure of the HCG injection, which may be confirmed by undetectable HCG serum concentration. And why that would be? Because if they've forgotten to dissolve the powder in solvent and they have only taken only the inert solvent. So if you have not mixed it properly and they have just taken the superficial part of it, all the powder would have been settled, like it would have settled down, and they would not have actually taken the HCG drugs. So that's why it may not have acted well. Or they might have taken a HMG injection instead of HCG. The timing might not have been proper, or they might have spilled the drug, and they might get scared that you will scold them. So they'll say that they've given it and not documented it correctly. So all those practical issues can be encountered. The other problem could be actually a biological problem where you have given everything correctly, but there was a rapid metabolic clearance than expected. Or it might have been a manufacturer defect in the HCG production. So because of which we'll have a reduced in vivo biological activity in some batches, and EFS can sometimes be labeled as a pharmaceutical industry syndrome. So very often when we come across, like if you are, as I said, it is not very common. So if you are seeing cases one after the other, definitely there is a problem with the drug only. If you have identified that, okay, there are no other. If there are no other problems, then we have to check the batch of the HCG which you have got and identify any errors in storage or any manufacturing errors. You'll have to discuss with the distributor whether there are any problems there. Sometimes they would not have maintained the cold chain there, so when it reaches you, you don't know. If you don't have mechanisms or people identified to check all this when you receive the batches, so then again we can have problems like this. Sometimes the bioavailability of HCG may be low after a bariatric surgery, and abdominal skin redundancy can alter the absorption of subcutaneous HCG. And so, in obese women, it is recommended that we give them intramuscular. A deep IM injection would be recommended. Or it may be an individual variation in the threshold for follicular response to urinary HCG. Then, when we talk about genuine empty follicle syndrome, problem may be an early oocyte atresia, or the absence of oocytes might be due to increased apoptotic gene expression and reduction of transcripts whose products are responsible for healthy follicular growth. So problems at the molecular level. Then problems due to aging, or it may itself be a manifestation of low ovarian reserve. So, does it really exist? Does genuine empty follicle syndrome exist or not? This is what the evidence says, and some suggest that genuine does exist and that it might be a real cause of infertility. And because they have found microscopic evidence of genuine empty follicle syndrome with a case of borderline empty follicular syndrome. Borderline forms, definitely where we retrieve less number of mature and or we retrieve many immature oocytes from several maturely appearing follicles. Sorry. The genetic basis for empty follicle syndrome provides strong evidence for the existence of genuine EFS. So it has been genetically established in some studies that there may actually be some issues because of which they are not adequately responding. So what genetic problems can be there? There may be a pericentric inversion at the chromosome 2 is to 46. That is, they'll have a normal karyotype, but there will be inversion in chromosome number 2. And this was seen in a patient who had multiple failed ovarian stimulations. And in a study published by O'Neill et al. In 2003, he said that it is an inherent condition of empty follicular syndrome with moderate sensory neural deafness, which had affected two sisters. So both of them had EFS and both of them had sensory neural hearing defect. And then one more study which was published in 2005, they found an inherited mutation of LHS to HCG receptor in two sisters with empty follicle syndrome. So, like two sisters having the same problem, encountering the same difficulty, might be pointing towards a genetic cause for it. So, what are the risk factors? One is advanced age, as we were discussing. It may be a manifestation itself of poor ovarian reserve. So, it may be more common in women who are more than 35 years, especially more than 37. It is more common if the infertility duration is more, like more than 8.5 years versus 6.5 years. If the baseline FSH levels are high, then you may come across it more significantly. And if you see low levels of E2 before HCG injection, then again it may be indicating towards empty follicle syndrome, obesity, as we were discussing, because of the altered bioavailability. And EFS may be a gradual biological occurrence related to ovarian aging. And what is the prognosis after EFS? If it is a sporadic incidence, then there will be good clinical outcomes in most of the cases, except 15% that are recurrent cases. And some studies have shown that you may even encounter poor outcomes. Risk of recurrence, to explain the patient, we can quote 15 to 20%, and they had a poor success rate also. Two consecutive cases of EFS, then we will not be able to do any further proper ovarian stimulation, and we would not even attempt once we thought two times EFS in the same patient. So, what is the etiology? In false empty follicle syndrome, following HCG trigger, obviously there is inadequate or absent LH surge. And the growing oocyte is surrounded by normally the cumulus cells, which are linked to the mural granulosa cells by cell-to-cell junctions. And these junctions tightly bind to the follicle wall, because of which we are not able to retrieve the oocyte, because that proper release or that gap increase in gap of the cell junctions is not happening. So they are all tightly linked and it remains stuck to the oocyte. To the follicular wall. Then LH peak. So whether you have given HCG or GnRH agonist, rupture of the intercellular junctions and release of the cumulus operous complex to freely float in follicular fluid, thereby which is available for aspiration. So this is what normally it should happen. So the junction should widen and the COC should get released and it should float freely, and only then you will be able to aspirate the oocyte. And there has to be a oocyte follicle crosstalk. Then normally there is a cooperation between the oocyte and the follicular cells, and that is extremely important. So there is exchange of material, and that ensures that actual nuclear cytoplasmic maturation happens, and the other cells get separated, and the oocyte becomes free. So the oocyte, in the oocyte, there is regulation of the cumulus cell functions by agents like GDF9 and BMP15, and any alteration of these may result in EFS. And in the cumulus cells, there has to be a coordinated oocyte development and maturation, which provides the energy substrate for oocyte meiosis resumption, regulation of transcription, and to promote nuclear and cytoplasmic maturation. So once we give the final trigger and the endogenous LH peak increases or the peak happens, the fundamental step of ovulation, and there is absence of any inadequacy of LH-like activity in IVF cycles, then it is false EFS, which we have already discussed what all could be going wrong. And so this is again like emphasizing about the genetic problems, what other problems can be happening. So if there is a dysfunctional folliculogenesis itself, as we were discussing about the genetic factors over there, so if the folliculogenesis itself is not happening properly, then the granulosa cells will have increased pro-apoptotic genes and decreased transcripts like PAP-A and MAPK3, because of which oocytes are lost in late folliculogenesis due to apoptosis. So there will be an early apoptosis, and the oocytes will be getting lost inside the follicle only. Or it may be ovarian aging, or faulty development and maturation of the oocyte. Sometimes, as we were saying, the strong attachment of the cumulus cells to the follicular wall because of dysfunctional signaling. Then there could be receptor polymorphisms, because of which the receptors are not acting properly, and that's why the HCG is not, the receptor levels are either not adequate or they are not there, because of which the HCG is not able to act. And then about the pericentric inversion. So what happens when we give a HCG trigger? It will act directly on the ovary. So if there is any, all these things we discussed, that if there is any abnormality in folliculogenesis, or the triggering stimulus is not proper because of receptor problem or in errors of administration, then we can come across this EFS. Okay. Then about GnRH agonist trigger. So what happens there is, if there is inability of pituitary to release adequate LH, failure of receptors on the ovary to mediate action of LH polymorphisms or LH beta genes. So basically, if there is any problem with the receptor, or there is a receptor polymorphism, sometimes women who are hypo, that is WHO type 1 hypogonadism in them, because the FSH and LH levels are extremely low, so the folliculogenesis will be impaired and the follicle would not have grown properly, because of which you will not be able to retrieve a good follicle, a good oocyte. Or there may be a borderline dysfunction of the hypothalamo-pituitary axis. Sometimes there may be a temporary hyposensitivity of the pituitary to the agonist. There may be again a GnRH receptor polymorphism, which may be causing this problem. So this we have discussed. We can do a follicular fluid may beta HCG levels. We can do or a 12-hour post-trigger LH, as I was saying, or you can do a 12-hour post-trigger progesterone also. So sometimes when we get, say, a value of 13 and 14, so we don't know whether it is really true or what is happening. So, most often then we repeat with the progesterone. So if we get this value which is low, to cross check also, we do a progesterone level, and if the value is high, then we can be sure that we are not going to come across this. And this I have seen in almost 2-3 cases where I got a low level of LH, but when we did progesterone, we got a good value and we were able to retrieve oocytes. And increase post-trigger progesterone concentration with borderline or low LH. As I was saying, we can have a successful OPU. However, if there is reduced post-trigger progesterone, but the LH is high, then usually there we will not come across completely like a EFS, but we will get lesser than the expected numbers. So there again, we counsel the patients beforehand that because the values are low, we might get lesser than the expected number of oocytes. And the peak LH levels post-agonist triggers usually occur 4 hours followed by a rapid decline. Okay, and shorter intervals, higher LH and lower P progesterone levels, and vice versa. So what would be our therapeutic approach? So if it is false, then as doctor you were telling, this is how we would proceed. We will give HCG and then re-aspirate after 24 to 36 hours after the second HCG shot. So that's why normally what we do is when we are doing a OPU, we would aspirate on one side and then wait at least for them to give a count. If we are not getting a count, then we do the UPT and then we can give a trigger, abandon the procedure, and then again plan a repeat oocyte retrieval. Sorry, this prevention spelling is wrong. How do we prevent it? So you can assess the serum HCG levels the day after the trigger. If beta HCG concentration is less than 100, then you can give a second bolus of HCG, or 24 to 36 hours later, you can plan oocyte retrieval 24 to 36 hours later. Or you can prolong the interval between triggering and the OPU. The strategy where little evidence to be generally recommended. So normally we won't do this. If you are giving a repeat trigger, you are sure that it has not acted, then we have to give an adequate 24 to 36 hour gap and then do the OPU. Or you can consider increasing the dose of HCG to 20,000 instead of the standard 10,000 which we use routinely. So that is the other way of doing it. Prolonging the interval between ovulation triggering and OPU, and inducing ovulation using agonist in GnRH antagonist cycle. Ovulation was triggered this with agonist 40 hours prior to OPU, and HCG was added 6 hours after the first trigger. So this is called as double trigger, okay, where you're giving both. You're giving agonist as well as you're giving HCG. So this is where you have already encountered one, like if previously she has had empty follicle syndrome, so in the subsequent cycle, you can plan to give a double trigger. Normally, if we have retrieved less oocytes in the previous cycle, not a EFS completely, so normally we would consider giving a dual trigger. So in dual trigger, we give agonist as well as HCG at the same time. In double trigger, they give it at an interval. Or you can, if you have used urinary HCG earlier, you can consider using recombinant HCG, or you can use LH to trigger ovulation. Now this LH to trigger ovulation, it is very expensive. The dose required is very high. So we don't practically use it. So genuine empty follicle syndrome can be managed in subsequent cycles by using recombinant HCG, or you can use recombinant LH, which is difficult to obtain also for the amount which is required for triggering. It turns out to be very expensive, and you can consider using a double trigger. How do you manage, like if the embryologist does not get any eggs after flushing 3 mature follicles, then you must stop the procedure, ensure that it was taken. So this is all what we have discussed already. Okay, so this is a flowchart about the same thing. So as you can see here, one ovary you have done, no oocytes are retrieved. Check for the premature ovulation and check if HCG was administered, and you can check the beta HCG levels. If it is low, then a rescue protocol, then you give 10,000 from a different batch. Don't use the same injection, because again, we don't know whether it was problem with the injection or with the administration. And then reschedule the oocyte retrieval later. If it comes out to be normal, then try another ovary. Then if you are still not getting any oocytes, now you have to plan. Now whatever you have to do is in the next cycle only. So repeat the cycle with gentle stimulation. I mean, a mild stimulation you can plan and then change the trigger, or use agonist in an antagonist down-regulated cycle to trigger with an endogenous LH surge, or you can use the same protocol but change the batch of the HCG. So this is how we would normally go about in empty follicle syndrome. And in the current cycle, as we discussed, we can plan a repeat trigger and then plan it at a later time. Okay. Okay, so to conclude, though it affects a minor population of IVF cycle, the impact is very, very large. And patients who experience this face psychological consequences, they have doubts about the possibility of finally achieving a pregnancy, and hence counseling is of prime importance. And treatment is largely empirical with very little case studies that do not help to reach conclusion about the optimum treatment. And wider knowledge is needed, and we need large multicentric studies to be able to give conclusive data about all these. Okay, any doubts so far?
Ma'am, dual
Yes.
trigger and double trigger.
Yeah.
It is not. Dual trigger means both agonist and HCG trigger. First one is 40 hours before OPU,
Yes.
and after 6 hours HCG trigger.
Yes.
And what is double trigger?
That is double.
This is double.
Yeah.
And dual trigger?
Dual is where we give both together.
Okay.
Any other queries we have? Okay, so we'll go to the second part of the discussion, which is about a premature LH surge. Okay. So what do you understand by a premature LH surge, and what would that result in? Anyone can tell? So normally what happens, like when you're doing ovulation induction, when you're doing IUI, and when we are doing IVF, what is the difference?
Ma'am, in case of normal stimulation or IUI, we
Yes.
don't control the LH surge usually. But in case of IVF, we control over stimulation, hyperstimulation. That
Yes.
means LH surge is in our control, in our hand.
Yeah, so there in IVF stimulation, when we talk about control ovarian stimulation, what is the most important thing is we are giving, see, there also in IUI also we are giving gonadotropins to help in follicular growth. Here also we are giving. But in IUI, sometimes we might consider giving antagonists to prevent a premature LH. But in control ovarian stimulation for IVF, we have to give antagonists to prevent a premature LH surge, because we do not want that to happen. In IUI cycle, even if it happens, you might experience early ovulation. And then if you have called her for a scan around the same time and you are able to document, you can still do an IUI. But in IVF cycle, if the surge happens and the follicles rupture before your oocyte retrieval, then the entire cycle is lost. So what is very important for IVF cycles is to control this premature LH surge. So that is something which is extremely important for completing the cycle and for giving a good outcome. Because sometimes also what has happened is, like, we would have given stimulation, there might have been some error. Again, I'll discuss about what all can go wrong during this and how it can happen. But sometimes we've also come across scenarios where we have patients started having pain just a few hours before OPU, and by the time we plan OPU, the follicles have already ruptured, or it may start rupturing when we have put the probe, and as we are aspirating, we may see some follicles getting ruptured. Okay, so that is again a very difficult situation to handle, because what we had expected, if say I had expected 10 oocytes, by the time I aspirate 2, 3, then I realize the others have already ruptured. So then with a good E2, with a good number of follicles growing, if we don't give a good outcome, again, it is a very, very stressful scenario for both the treating clinician as well as for the patient. So here I've given another name for it, that is premature, progesterone elevation on the day of HCG administration in IVF. So to start with the introduction of GnRH analogs for pituitary suppression in IVF significantly decreased the incidence of premature LH surge. So that is when the GnRH analogs were started in around 1992 to prevent this premature LH surge from happening. However, several researchers have described the phenomena reported as premature utilization. In various studies, they have described it. So PL, that is rise in progesterone on the day of HCG administration, has aroused interest, and some authors reported decreased implantation and pregnancy rates also. Because if you have planned a fresh transfer and the progesterone has already risen, then obviously the endometrium will go out of sync, and then it will result in a lower implantation and pregnancy rate. And some have described cryopreservation of the embryo and transfer in subsequent cycle if you have come across this premature progesterone rise, or HCG administration at an earlier time prior to the progesterone elevation. So what is premature luteinization? Many authors in past have adopted this term for progesterone elevation on the day of HCG administration. That is, you have given antagonist, you are not like you have made sure that the LH does not rise, but still the progesterone is rising. That means it is undergoing premature luteinization. So what happens is that there will be excessive amount of progesterone which is produced by granulosa cells that have started the process of luteinization. The use of the term premature luteinization in the presence of normal LH surge is not appropriate, at least when a GnRH antagonist is used to inhibit the LH surge. Agonist is used. So this is about the agonist cycle. So normally when we are saying that the progesterone is rising, obviously the LH would have also risen, isn't it? So once the LH rises, that surge, and then the progesterone surge happens. Especially when you've given an agonist. Why? Because in agonist, you have ensured that she has been down regulated over a time. In antagonist, it is just a short lasting down regulation. But in agonist cycles, it is a long term down regulation, and almost the receptors would have also got down regulated. So there, if you are not able to document a LH level also rising, then it doesn't become relevant. Then increase in progesterone in the late follicular phase may be unrelated to any luteinizing process, and it may be attributable to the effects of follicular cells to the LH. And what would be your progesterone cutoff levels? So normally between 0.8 to 2. Again, there is a lot of controversy about this, about the real levels. But normally, if it is more than 2, then we would consider definitely the progesterone is high. Or in some studies, they have considered the ratio of progesterone to estradiol. If the ratio is more than 1, then they would consider it as premature luteinization. And we have to consider the ovarian response in toto rather than the serum progesterone only. And the differential diagnosis between progesterone secretion from a dysmature follicle and physiological secretion from multiple healthy follicle has to be established, and only then we realize whether it is significant or not. So sometimes in hyper responders we may come across scenarios where, because there are many follicles growing together, each one will be secreting some amount of progesterone, and because there are say 30-40 follicles growing, you may see that the progesterone levels are very high, but usually the LH levels will be very low in them, especially in donor cycles we see that. So there again it's not of much significance. But if you are seeing that she's a responder or a poor responder, LH is rising, with that the progesterone is rising, then we are in trouble. So the incidence, there is a marked variation in incidence, and there are a lot of discrepancies are there because we don't have a clearly defined population characteristic, or we don't have the proper cutoff levels to really identify it. And even among studies in which the same definition was used and same protocol, they found different level of incidence. And if we use only progesterone to define, then the incidence will come almost to 13 to 70%. But if you use the ratio of progesterone to estradiol of more than 1, then you can cut it down to almost 41% cycles. You can come across this situation. So, what is the pathogenesis? It's poorly understood, and different hypotheses have been suggested. One is probably because of elevation in the follicular LH levels. There is pituitary desensitization induced by the GnRH agonist, which is incomplete, and because of which the rising E2 induces increased LH sufficient to stimulate the granulosa cells to produce progesterone, but is inadequate to trigger ovulation. So, as I was saying, when the response is more, then because of the increase E2, it will stimulate them to produce progesterone, but it will not really cause it to trigger the ovulation. And if you've given a long agonist protocol, then that can prevent premature LH elevation in 95 to 98%. As I was saying, in agonist protocols, because you've given it for a long time, so the receptors themselves get down regulated. And because of which there is a very rare possibility that you will come across premature LH surge. And increased LH is not the only pathogenic factor in premature luteinization. There may be serum accumulation of HCG from HMG. So it may be a problem with your drug only. So whatever HMG you are giving, if it has HCG in it, then that will also cause the problem. So HCG is higher in women who experienced a serum progesterone rise during a GnRH agonist HMG protocol, despite suppression with the agonist. So with the HMG, you are actually adding HCG, and that will be stimulating the follicles to produce progesterone, because of which you are encountering the high progesterone levels. Or if you have used recombinant FSH, which will have a negligible intrinsic LH bioactivity, then you should not come across this scenario, because there is no impurity, there is no chance of anything which you are giving exogenously, which is triggering the progesterone release. The serum progesterone rise was similar with the use of HMG or with recombinant FSH, and HCG content of HMG is not the only cause, but we cannot completely attribute this. It may be some other inherent problems also, because of which the progesterone is rising. Then third is increased LH receptor sensitivity of the granulosa cells to FSH, and higher cumulative exposure to estradiol in conjunction with the FSH. Or sometimes it may be a poor ovarian response with increased LH sensitivity. So they may be overtly sensitive to LH, and if you're supplementing with HMG, then they tend to respond more and produce more of progesterone. So when you consider the definition in terms of progesterone to estradiol ratio, that was more prevalent in women with poor ovarian reserve or poor responders who were given long GnRH agonist cycles with recombinant FSH stimulation. So when you've given RFSH, you're sure that okay, there is no HCG over there. So then it may be due to the increased LH sensitivity. And PL is not necessarily an LH dependent event. Sometimes it may happen irrespective of the LH level also. And premature luteinization is related to an adversely affected cumulus oocyte complex. Increase in progesterone in late follicular phase is unrelated to any luteinizing process attributable to the effects of follicular cells to LH. So how does it impact your IVF? Impact on IVF, it is controversial. It does not affect the pregnancy rate, which has been proven in many studies. In fact, some studies have told that if the progesterone levels are high, we can freeze the embryos, but overall oocyte quality will not be affected with this. However, it will have a deleterious effect on the pregnancy rate, and that has been inversely related to the serum progesterone levels on the day of HCG administration. So as I was saying, because the endometrium will go out of sync, so there will be a premature rise in progesterone, so the endometrium will get deserialized early, and that's why they will not be able to conceive. So, what effect will it have on the ovary? It may have adverse effects on oocyte maturation, fertilization, or even early cleavage. But these were all very early studies. And on the other hand, poor embryo quality was not found. So, however, though it may slightly affect those factors, but usually it will not impact the embryo quality. And obviously endometrium, it will have adverse effects on implantation and subsequent embryo development. So as I said, there are a lot of controversial studies. So here they said in these studies in the 1990s which were done, that they didn't find impact on the embryo quality. However, there were some studies again in those times only where they have told that it may impact the embryo development. And when there is an abnormally accelerated endometrial maturation, the receptivity will be impaired. And if you start progesterone supplementation for luteal phase support on the day of HCG itself, then it will not negatively impact the pregnancy rate. So those were the early studies which I was quoting. So now this was published in 2007, where they have studied whether elevation of progesterone on the day of HCG administration is associated with the probability of pregnancy in IVF. And this was a systematic review and meta-analysis. And to analyze this only, whether if progesterone is high, whether it will impact any chance of pregnancy or not. And they identified 12 studies and 10 of which were retrospective. And what they concluded that the best available evidence does not support an association between progesterone elevation on the day of HCG administration and the probability of clinical pregnancy in women undergoing ovarian stimulation with either analogs or gonadotropins for IVF. So it will not affect the pregnancy rate much. And then sometimes there may be, okay, this is something else, sorry. So to summarize about premature utilization, a subtle rise of progesterone on the day of HCG administration is what is called premature luteinization. The incidence varies between 13 to 71% because of the various different criteria and the different population characteristics and treatment protocol. And what we can summarize as the hypothesis is, one is elevation of follicular LH levels, serum accumulation of HCG from HMG, or it may be an increased LH receptor sensitivity of the granulosa cells, or due to poor ovarian response with increased LH sensitivity. And as we have seen that there are many controversial studies, so whether it will really impact the IVF outcome or not is controversial. We do come across these scenarios where the progesterone level is high. And in such scenarios, what we are very careful of is to plan the trigger a little early, and we usually admit such patients a little early, and as they are admitted we ask them whether they are experiencing any pain abdomen or not. And if they say that they are experiencing pain, then we would do a scan and try to see how it was at the time of trigger and how it looks now. If we feel that the fluid is more, and if the follicles seem to be like going in for premature ovulation, then we would try to do the oocyte retrieval a little early. So if your planned say at 8 o'clock, we would make the process fast and try to do by 7:30 so that we can aspirate as many follicles as possible. There are there are a lot of studies about this, like what other measures you can take. The other thing is you can consider giving NSAIDs, because NSAIDs are known to prevent ovulation. So if the progesterone is high and we are not planning any fresh transfer, then we would also consider giving NSAIDs like indomethacin or ibuprofen to prevent a premature ovulation, because that is what we do not want to happen with this. And overall, whether it will impact the oocyte quality or not is again controversial. So one thing is we have to make sure that we are able to retrieve all the oocytes. So these are my references from Gardner's and from these textbooks. So that ends my talk today. Any questions about this?
What if we plan for fresh embryo transfer?
Yes.
What is the cutoff value? Up to 2 of progesterone.
Normally we take it as 1.5.
1.5.
If it is above 1.5, we don't plan the transfer.
Okay.
And you also have to see the endometrium, how it looks. Very often, what I have seen is when we are doing the stimulation, and like initially you will see that it is nice triple line, and gradually when you see, especially for hyper responders, you will start noticing that they start becoming early secretory pattern and all. So you have to also look for the endometrium, and invariably when we start seeing the secretory pattern, I have seen that on the trigger day the progesterone level will be high. So that means the endometrium is already advancing.
Yes. Okay, ma'am. Thank you.
Any other questions? Because these two are very important topics, and those who are planning to do IVF, their own IVF stimulations, or if you have already done, you will be very well aware about these. These are the two things which we are very scared of. One thing is all follicles rupturing before you do a pickup, and the other thing is coming across a scenario of empty follicle syndrome. So you all must be aware about it. And for further details, you can read some recent articles also, and then whatever clarifications you have, you can seek in a subsequent class. Thank you all for a patient hearing. Bye.